Okay. Hang on. Let me get in the right course. Okay, SLP 215. Welcome. All right. So some of you are still turning in your midterms. Please do that by tonight. So far what I've gotten, I've just looked at them. I haven't posted any grades. But I will start trying to get those because they do take me a while to grade. So I try to get on it. But auditory processing. So let's talk about that. All right. Oh, here we go. One more person. So auditory processing. A couple things. This is my, I don't want to say what least favorite. Maybe that's not the right term. Auditory processing disorders is always difficult for me to talk about because I don't want to say it's not a real disorder. That's not true. I feel like auditory processing disorder should occur without other co-occurring things. So I think it's always hard to tease it out. Like I said, I've worked with maybe 4 people who didn't have a hearing loss, who truly had auditory processing problems, and I see it a lot with our adult population after, a stroke or something along those lines. That definitely what they're processing it differently. So auditory processing is always a little challenging for me in the way that I learned it, and it's evolving. Number one thing though is your SLP, she doesn't diagnose that, or he, excuse me, they, the person, your supervisor. Sorry, I'm trying to use inclusive pronouns. It's the audiologist. The audiologist is the one. So if your supervisor suspects auditory processing or somebody else does, they are referring to an audiologist to make that determination. So let's review some things. Oh, whoops. One second. Excuse me. I constantly do that on this. I hit the wrong next button. So, basics of processing. Here we go. The problem is not in the perception or the reception of the signal. Repeating the signal is not usually helpful. And I like this. At best, it's minimally effective. And it's basically how that person is uniquely processing what they hear auditorily. So again, processing is kind of that second step. So it's not just kind of, are they hearing it or are they not hearing it? It's the meaning that they're attaching to what they're hearing. So you can kind of look at the definitions. So just, if you're Googling this, central APD, central auditory processing disorder, it's same thing. And it is a hearing problem, but it's not a hearing loss. So it's problematic, but it's not a hearing loss. So a hearing aid is not going to improve their processing. So it's that next piece of the cognitive. So it's not just hearing the signal, it's applying meaning to the signal that you hear. So kids with this condition can't process what they hear in the same way other kids do. So it's like there's not a coordination, and something interferes with the way the brain recognizes and interprets the sound, especially speech. So here's what I want to say. What I see when I see people with, and I say people, I'm talking generalities here, not every case. But for instance, if somebody, let's say with a diagnosis of cerebral palsy, I already know there's going to be challenges with processing in some way, but be that motor and planning, be that motor, be that some kind of other cognitive process. So a lot of times too, like I said, one one particular student I worked with for a long time who had cerebral palsy. I do think he had auditory processing, but I think felt like it was a result of his cerebral palsy. It was part of his disability. It wasn't in absence of, it wasn't by itself. It wasn't a standalone thing. So definitely we know that if we are looking at somebody with some maybe neuro type disorder, I imagine they start to have problems with processing. I can infer they probably do in some capacity, depending on the diagnosis. The other thing too, muscular dystrophy seems to, I feel like they start to have some challenges there because they're having breakdown in certain muscles and things like that. But definitely when you look at the brain, how there's some breakdown in the brain functioning, I can see that. So auditory processing occurs in the temporal lobe. So this is some, nice review of our brain anatomy. So when you look at kind of the visual cortex, auditory cortex, so somebody who's had damage to the temporal lobe definitely can have challenges with auditory processing. So the cause, here's what we know. Evidence suggests head trauma. I definitely see people who've had head trauma now have difficulties, but we don't call it just auditory processing, we call it a TBI. Lead poisoning is another one. So there are certain areas of the country, or you might work in a particular setting where there are people who have lead poisoning, and we definitely see problems with processing with lead, exposure to lead. Chronic ear infections. Now, I truly believe when I look at auditory processing in and of itself, so we don't know what's going on, we're trying to figure it out. I have one child right now that I think his true issue, he does not hear things. He does not have a hearing loss, but I know he had multiple, his history, lots of untreated ear infections. And so as he was developing language, developing the sounds, that kind of thing, it created some kind of distorted processing issue because he doesn't have anything else. But man, he definitely has auditory processing problems. So he struggles with it, makes him incredibly frustrated. But given his history and his past, he had multiple systemic, and then we also suspect he had meningitis. I don't know. He was adopted out of a bad situation, so we don't know the entire history, but we think maybe one was meningitis, which makes sense to me. So I would say that's a cause, but again, I'm not the neurologist or the doctor making that diagnosis. And so you kind of look at the 5 problem areas. So really, your supervisor, she'll read the report, or they will read the report from the audiologist about where they're having challenges. Is it auditory discrimination? Is it auditory memory? Is it, figure ground problems? So, for instance, and maybe sometimes I have this, like the background noise. It's really, really hard to focus here or pay attention to what they're listening to with other background noises. Auditory attention problems. So this is my other big beef with auditory processing, and these are just my own personal biases, is a lot of times if I see CAPD in a report, something along those lines, and then I see ADHD, I'm not saying they can't co-occur, but it's really hard to tease out auditory processing and attention sometimes. So again, if it's just auditory attention and then they have ADHD, that makes sense to me. But again, auditory cohesion. So this is when like higher level listening tasks are more difficult. So again, we're trying to extract higher meaning from the signal. So there's some of that. So primary CAPD subtype. So usually what we see is one of these things in a report. So, and really what I'm looking for is what are some of the other deficits we see? Poor discrimination. So myself as a speech therapist, that's what I see. or they mishear what was just said. So I don't know. Maybe some of you live with someone who mishear what you say. I don't know. I have 5 people outside, and mishearing 4 people mishearing what I say, or 5. I want to include my husband, but what I see, especially in, I had one clinic person who came to me, and they were an adult and really starting to have some deficits. And again, I don't know their previous history. Maybe they always did, just now as a young college student, they had more identification of where the breakdown was occurring. So definitely, that person definitely had some auditory decoding deficits, but we also saw some other things when they went to the audiologist. This was a person I worked with in grad school. The audiologist sent them to the neurologist because there was some kind of deficit happening, or some more concerns of some bigger neurological things going on. So and that was always a case I think about, because we didn't have an outcome. They didn't come back. So I was curious as to what the neurologist found, but definitely too is information they do perceive is often incorrect. So the information given was correct, but what they perceive is incorrect. So again, teasing some of that out, perception, I think sometimes that's, there's a lot of things that an audiologist has to kind of infer from that. So reading, decoding, comprehension, spelling difficulties. There's a lot of reasons for that. But auditory processing might be a component in that. So just because in usually speaking, when we're reading auditory processing, we are giving more compensatory strategies or accommodations, not so much treatment. We can't make it go away. So anything with processing, we can't make go away. We can only work on compensatory strategies to address it. So most of the time, therapy itself is not going to make it go away. We're just going to help them learn how to deal with it. So there's some things there. So a lot of times, like, we have children at school that might have this diagnosis. It's just usually some accommodations that might be on a 504. We might have somebody on an IEP, but if that's their main diagnosis, that's usually most of the time just a 504 for some accommodations that they're going to need. And a lot of times too, what we need to do for people who have auditory processing disorders is teach them when they need to check their comprehension. When we teach a lot of self-checks. So I think what I work on, when I say compensatory strategies, a lot of times when I say that word, I mean a self-check. Do they know enough to check on, okay, I might have not heard that correct. I might have misinterpreted information. What do I need to do to make sure that I have the correct information? So a lot of what we do if we're treating it per se, is we're working on, does that person understand when they need to self-check, when they are, listening to information, strictly listening. So this is where visual cues help our people with auditory processing disorders, that they also have a visual. So like giving information, perfect example. This one particular student I work with, who I do think has the severe auditory processing disorder, like if it's visual, it needs to, so if a teacher gives an auditory direction, like she just verbally says it, then it needs to be written down too. So this particular student needs all directions written down. Clearly and honestly, that helps everybody. That's a good strategy. So definitely, I try to prep many of the teachers that work with this particular student, because the student's capable. Just really, they see, if they don't do it, they start to see the breakdown. So prosodic deficits, doesn't follow oral directions well, loses focus very quickly. And then some flat affects. So a lot of times too, these kind of situations. So for instance, people with autism typically have auditory processing deficits. It's not a separate disorder, it's part of their autism. So we know autism is a processing issue. They don't, process sensory. So auditory, think auditory sensory. I also feel like this is kind of another strand on the sensory processing problems. Um, and a lot of times we think sensory auditory, we're thinking more like defensiveness or sensitivity, but this kind of falls in line too. And really, for instance, think of how that might impact somebody socially if they're misinterpreting information or mishearing information. So that can definitely have a lot of social consequences. So here's this thing. When is it not auditory processing? When they just misunderstand the meaning. So they don't know what the words mean. So that's where your supervisor will tease out. Do they have the language understanding? Noise is not a major issue. Responds incorrectly to questions and information. So again, this is all hard to tease out, and this is why they usually require several types of testing to figure out where the breakdown occurs. So a lot of times they may appear non-compliant, and deficits can be in all or some areas. So for instance, what we usually see is if somebody has extensive language deficits, then it's usually not auditory processing, it's language. It may look sometimes like auditory processing. So that's why a full language battery is always recommended before somebody's given an auditory processing diagnosis. So the speech pathologist and the audiologist usually work hand in hand to tease that out. So again, you kind of looked at some examples. Let's stop at that one. But I feel like many people have a hard time wrapping their heads around auditory processing, and that's okay. Because it essentially should be an issue where nothing else is present, and it really is, and some of it's hard to tease out. So intervention, remediation management. So really when we're looking at remediation is really formal and informal therapy to develop deficit skills and teach compensatory strategies. Management is how do we help them accommodate their environment, modification of the environment, use of compensatory strategies so they know the compensatory strategies, can they use them? So sometimes when we work with somebody with an auditory processing issue, we're working on teaching the compensatory skill, and then when we're looking at the management, implementing the compensatory skill that they know. So for this particular student I've worked with for a long time, he's done a really good job of knowing, and his comprehension is good. That's what's so funny. His teachers all say, God, his comprehension is awesome. Yes, but he has to have the right environment to get the information, and when he does, he has it. But if it's strictly auditory or given strictly auditory, that's not the avenue. That's not his learning avenue. So he knows how to ask for things, how to alter his environment to make it optimal learning for him. And then we try to minimize adverse effects of a disability. And really that's what management piece is. And sometimes that requires direct therapy and sometimes it doesn't. A lot of times what we're looking at is we start with a remediation, teach them these skills, and then we really kind of start weaning them off services because they're able to manage them. So yeah, recommendation for management are 3 areas: compensatory, environmental modifications, direct treatment. So a lot of times in direct treatment, we're working on what works for them. What are the compensatory skills do they need? And then how do we alter their environment to make it optimal? And this is true for not just auditory processing, this is for a lot of different disorders that we work with. So remediation. Some things we look at is preferential seating. Again, we look at the handedness of the teacher and where does the teacher usually talk from. So we're really working on what's the optimal environment. And that may look different from client to client. And then you kind of look at this, and typically speaking, especially in a school, so auditory processing really affects them a lot in learning in their education. So, and then as an adult, let's say you have something as an adult, it can really affect your job. So definitely some things that they might need to do for themselves to support, you know, their ability to work and function. So some other things like noise reduction, definitely using some of that. Carpeted floors. So if you ever worked in a place with, you know, just concrete floors, how much reverberation there is. Amplification systems. So what that is, again, a lot of people say, oh, that's just making it louder so they can hear. What that does is it cancels out some of the other noise. Or the one student, actually, I've been advocating for him to get an FM system where he goes directly in his ear because he's very distracted by all the other noise. It's really hard for him. And a lot of times he asks for quiet, but if he could have the teacher just speaking some of the other, you know, 8th grade, a lot of extraneous noise in middle school. So we were kind of working with that. Actually, I was talking to the audiologist last week about maybe an FM system where, so it's microphone directly into his ear, but the teacher was saying, actually, I'd like it just for the whole class. And those are really good. So I think everybody benefits from in a teaching environment if it's amplified. So what do we do as the therapists? What are we doing? So we're maybe training them, where do we localize sound? So you're trying to focus on something, and what do you need to do to alter, you know, the other sound? So where do I need to stand to localize the sound? Train clients to recognize how to change attention and speech sound sources. So really, how do we focus on the speech? What are we doing? So this is also things too where we really work on visual attention. So if you're visually attending and you're watching and you're in a good space to hear, those are all cues you need to help you get that information. And really some other metacognitive skills. And what that means is think about your thinking. How do you know what helps you learn the best? And what are some other things too that are just helpful to know? So main idea is really good. Sometimes we need to teach them how to ask for clarification, or how do we know to key into keywords? So I do kind of do a group with the middle school age of keywords. I do a lot of that in adult rehab. What are the keywords? What are the key things you need to be listening to make note? So a lot of times we'll start with keywords in the doctor. What are keywords a doctor says? What are things you need to take notes of when you're meeting with a doctor? Or, you know, then maybe job skills is the next one. So role of speech therapy. Here on the students or pre-readers, we determine if students need to work on discrimination. So that auditory discrimination, and really that skills are identification of sounds and syllables. And then we use a lot of minimal pairs. So if you look at kind of some examples of minimal pairs, and I know you guys have talked about it in 214, and that's really that piece. So it's kind of along those phonological awareness skills. Can they identify the initial sound? Can they discriminate between, you know, two words that are close to kind of those word families are really nice. So we got like, what was I doing with some kids today? Like pain, gain, drain, how they're similar, but they're hearing that difference in that first initial sound. That one little girl, boy, she does not have any. My intern definitely noticed that today. She's like, wow, okay, we got to work on this. Yep. So phoneme to grapheme. So just remember, phoneme is the sound. Grapheme is the visual representation of the sound. So again, we work on having them look as well as listen. So seeing the word, seeing how it's represented, and then listening to it also at the same time. Definitely some things that we do there. And really what we want, the orthographic symbols. So the problem, again, and I will bash our language, English. So for example, we have, what is it, 26 graphemes, so 26 letters. But, oh gosh, I'm pretty sure, and I might be wrong, but I think we consider 46 phonemes. We have 46 phonemes, but 26 graphemes. So we have double the amount of sounds in our language versus how many, visual representations of them. So 46 phonemes for 26 graphemes. And then we have things that say the same, or we have different visual representations for them. So like F. So PH and then the F, both say. That is really hard and that's not kind of a, I don't know, what's the word? A consistency within English. Sometimes we write this, sometimes write this, or like C. C sometimes can make the cuff sound, sometimes can be. So that gets hard. And when you teach, just teaching some of the exceptions to the rules are really challenging. That's why English is a hard language to learn. And then phonemic processing skills, going down all of these things. And we work on that. A lot of speech stuff, we're working on this, working on memory. So teaching those compensatory strategies, as well as what are some other things? So those episodic strategies. So I don't know if you guys, I just remember, it's so funny, I must use this. So I could be reading something, trying to learn something, and then really taking into account. So if I'm trying to recall it, I have to remember where I learned it. Like where was I sitting? What was I doing? Especially when I'm doing some of this stuff on speechpathology.com, I was doing a little refresher on some disorders I haven't seen in a while. So, and I have one. So I was doing that, and then I was like trying to remember to take the test to get my CEUs, and I'm like, okay, I was downstairs. I was, trying to listen, but it was too loud, so I had to go upstairs. I remember I was reading that when I decided to get up and change. So where was I? So definitely teaching people what helps them remember. That's what's hard, I think, as therapists, when we try to give them some things to try, and some of them work, some of them don't. So other things, procedural strategies. So we teach with movement. So what does it sound like? You guys teach with movement, embed emotion in learning, like things, other components. So this is kind of that multi-sensory experience. What helps you with your memory? What were you doing? What were you smelling? What were you feeling? All of those things help you recall information. Those are meta memory strategies. And this is kind of that multi-sensory learning, which is why it's effective. That's why it's evidence-based, because we know all of those things help people recall those things. So barrier strategies. So I like doing this, kind of doing some things that change the environment during activities to see what's more beneficial for them. Definitely, I try to do that in a lot of my therapy sessions sometimes, and looking at what helps them. So for instance, when looking at work time, so some of us are more alert, some of us can focus better, some of us can implement strategies better at certain times of the day versus others. And then some classroom stuff, look at that. And what can teacher or parent or boss do? So really looking at supplementary the auditory information with, see, this always tells me, this thing pops up, tells me, hey, you're taking too long. You're getting too long-winded. So supplement auditory information with visual. I would say that's a number one thing that really helps and supports our people with auditory processing. Allow them time to process. So throwing things at them, rapid fire is probably not super beneficial. Giving them cues for the attention. And again, allowed for varied responses, and as well as shortened length of things. So some tasks can be longer than others. Definitely it's hard, so the more you have to listen, the harder it is sometimes to maintain attention. So kind of those shorter, more frequent um, things are better. So for instance, at work, I feel like my principal does a good job. She's like, okay, when we do, instead of doing an hour and a half, staff meeting where you have to go through all, we've been doing new procedures up the wazoo with COVID, and I feel like it changes every week. So we have to have, so she's like, okay, here's a 10-minute update on procedures. So she just does like 10, 15 minutes, and she'll have a few more things instead of one, 2-hour staff meeting. She tries to break it up. So I do appreciate that, because after 10 minutes, I'm not listening anyway. Um, but she was telling me she learns better. She can recall information in short bursts versus sitting through 2 hours. So I appreciate that. So what are some other things they can do to advocate? Additional time, ask specific questions for clarification. Listening, tape recording, and being able to go back through it is helpful. So if you are one of those people, you like to hear things again, or make sure, you check, make sure you did understand it. That is helpful too. And then one other thing too, collaboration. So a couple other things I want to just say is that a lot of times processing happens all day, every day, everywhere. Everything you're doing, you're processing your smells, you're processing your visual, you're processing your auditory, processing all your kinesthetic things. So your body is processing all of this. And sometimes so for instance, was fun, a kid today verbalized something. He was having a bad day, really rough. We didn't know what was going on. And I always am super excited when I have an intern and they can kind of see this happen, because they talk about stuff like this. So, he's thrown a fit. He's not, he's communicating his angry very well, but we finally got him to sit down, and I said, okay, all I want to know is, what are you feeling? Okay. And basically I went down through some questions, or some cognitive questions I ask. And then finally, after the third question, he's like, I don't like my pants I'm wearing. And then he started to verbalize exactly what was bothering him about his pants. So I was like, okay, well, let's try and fix this. Let me cut this thing that's hanging off here. Had these strings kind of hanging that were bothering him. And it was kind of like rubbing the back of his legs. And I'm like, look, we just cut the strings that were loose. Is that better? He's like, oh, I feel so much better. It's not bothering me so much. I'm like, okay, cool. But he couldn't sit down, focus, do his math in the morning, because he was feeling something. So he's pretty sensitive. Like, his kinesthetic processing is definitely, if he's not, I don't know if any of you are like that. Like, if something doesn't feel good, you just can't get settled or focused or ready to do what you need to do. It's why we all like to put on comfy pants when we get home. So, I was like, okay, well, that's what you need to tell us. You need to describe to us what's wrong so we can help you, So it's always fun to see a kid actually communicate some things that he clearly wasn't beforehand. But so those are just some things to think about. So auditory processing is hard to quote unquote treat. And sometimes it's a lot of trial and error with the person to figure out what benefits and works for them. So that's what makes, I think, for me, auditory processing difficult, because I feel like there's so many factors. It can get difficult to tease out, but you don't have to tease that out as the SLPA. You just have to do what your supervisor recommends to help the person, and hopefully they can reciprocate and communicate some things to you back. But any other questions? So we just have there's 2 assignments and then a quiz this week. And please turn in your projects tonight. Any other questions? All right. Well, thank you guys for